I think it's on now. I think the microphone is on. I'm the first one here, so when you get here, pop something into the comments. Let me know you've arrived. Hello, hello. And then we'll determine if you can hear me or if I'm talking to myself. Hi there, I see some faces. Pop in the comments, let me know that you're here and that you can hear me. Because I'll usually start talking and say a bunch of really great stuff and then realize that, oh, my microphone was off. Hi, Dina. Okay, so I'm assuming you can hear me, Dina, and anybody else? I'm thinking so. Okay. Very good. Yes, thank you, Jacqueline. You've probably been on here before when I've talked and you guys haven't been able to hear me. Hi, 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 hi. I'll give it a minute so that we can get a few more people on. I know there were a bunch of people interested. We're going to be talking about safe medication administration. It seems really topical right now with everything that's been going on in the past couple of weeks in the news with the Redondavat case. So I know a lot of students are really nervous about giving meds and being out there on your own, especially those of you that are about to graduate and it's starting to feel really real, right? So let's just take a quick minute. I'll let a few more people join. I'm just going to take a moment, look down here at my list, see who's showing up. Ashley and Ashley, hello, hello. Hi, Lillian. Hi, Erica. I recognize a lot of names here. Lizzie and Kelly and Amanda. I recognize Amanda's name. Jacqueline Vasquez. Yep, I see a lot of you guys in the group all the time and on the Facebook page, so it's great. Okay, so let me just see. I've got my notes. I've got those notes. And we have about 20. Okay, let's get rolling. Okay, first, let me get some water. So if you've listened to my podcast before, you may have seen or heard me do a whole episode on safe IV medication administration. So let me know in the comments if you've listened to that one. I'm just curious if you guys have heard that one. What we're going to be talking about today is kind of a general safe medication administration kind of guidelines. And I know that probably that first week of school that you were a nursing student, they started talking about the 5 rights, right? Like that's the backbone of your medication administration. It is there to keep you safe, keep your patients safe, give you like this systematic way to think through what you're doing at the bedside. As I started working as a nurse, I realized that wasn't enough for me. I needed to do some more clinical judgment in the moment around medication administration. So I developed this kind of framework called Bulletproof medication administration, where I really think I've thought of everything. I added to it this week. I'll be honest. I added to it this week because I realized, oh my gosh, that is an actual thing that I needed to add to this. So we'll talk about that when I get to it. So I have this whole list on my website, you guys, and can I? Ooh, I can. Hang on. Let me put the link. I'm going to put the link to it. You just go and you sign up and you get this free Bulletproof medication administration list. I put that in the comments. We're going to start with the 5 rights. Okay, I'm going to talk about those, share a little bit about maybe just like at the bedside for real, what it's like to do this so that you have a little bit of real world framework around that. So of course, the first one, you guys, the right patient, right? The right patient. And that might seem like no brainer, right? But you'd be surprised, okay, that there are patients that have similar names, right? You could have 2 patients with the exact same first name or the exact same last name or really, really similar names. So super simple to mix things up there. Luckily, though, you've got different ways to verify the right patient, right? You're looking at the chart, you're looking at their name, you're looking at their birth date, you're looking at their MRN, and you're comparing that to a physical thing on the patient, like their armband, right? And asking them if they are awake, alert, and oriented enough to answer you. So you've got safety check there, right? Even if the patient has a similar name to someone else on the unit. Now, where I work, when there are patients with similar names, there will be on the chart on the Pyxis machine, like this name alert thing. Have you guys, anybody seen name alert on the Pyxis or in the chart? I will also, in the ICU, I would also like print out, like make a little sign and put it in the Pyxis room. Name alert. We have 2 Johnsons today. The board on the wall would say name alert. Like everybody was like, okay, we've got 2 Johnsons on the unit today. Let's be really hyper aware of that. Another reason you want to really make sure you're doing right patient. I don't know about you guys. I don't know how much you're in the chart as students, but, or maybe some of you are working. How many times have you been in a chart 100% in not the chart that you thought you were in? Like I've started documenting, I've done a whole head to toe assessment in the flow sheet on the wrong patient because I've got the wrong chart open. I really think that here's my improvement for Epic. We use Epic where I work to have each patient a different color. Wouldn't that be easy if you knew Bob was blue and Mr. Wilson was orange and Roberta was green? Like that would be so great, but they're not. They're all the same. So it's really easy to do. So right patient, I know it seems super basic, but you always can just fall back, armband, and ask them. What if they don't have an armband? That is a huge deal. If your patient does not have an armband on, and I've seen patients come out of surgery without an armband on, it's just on the bed. That's not acceptable. Maybe it fell off because it was too big. Maybe the patient got really edematous and it was cutting into their skin, so someone removed it. Like these things happen. So if you ever get into a situation where there's no armband, get your charge nurse involved immediately, okay? And you'll need to get that patient re-identified. But always falling back on those 2 unique identifiers: their name, their birth date, their name, their medical record number. Those are the most common, okay? Anybody have any questions about that? I'm just looking at the comments. Name alert by the room number. Okay, Kimmy, great. Yeah, name alerts are fantastic. Okay, and I think Cleo is saying that she's been in the wrong chart before. Yeah, I do it all the time, and it's really annoying because then you have to go and erase everything you did and then rechart it. You can't just copy and paste from one chart to another. So yeah. Okay, so that's right patient. How does everybody feel about, okay, I feel like I can, with confidence, know I am at least dealing with the right human being that I expect to, because I'm just going to fall back on that very basic check. Look at their armband, look at the chart, ask the patient. If, you may also have someone in the room, like maybe it's a, elderly patient with dementia. The other person in the room can also help verify, but still you're looking at those things, okay? All right, so that one, I feel like we all know that one, right? Right medication. This is one of those where, don't ever assume. Make 0 assumptions about the medication that you are giving. You have to look at it. So with the case that's happening in the news right now, I read the court documents this morning and tons of red flags, tons of warnings, tons of just safety barriers just blown past when one look would have made a world of difference. Like, it's heartbreaking to even talk about, but eyeballs on the medication. I work in the recovery room and it's dark in there. We keep it dark because we want people to be, chill after their surgery because they can be confused and all of that. And it's just better if they kind of ease back into reality, right? It's dark. I don't see that well in the dark. I got to get my readers out, and you better believe I turn the lights on to look at my medication vials. I get my glasses on, I look at it. So making sure you have the right med is 100% critical. I know it sounds like a no-brainer, you guys, but again, apparently not. Many medications look alike or sound alike, okay? So some great examples of that are dopamine and dobutamine. How easy would it be to mix those up if you weren't like super sure what you were doing? Okay, those are ICU type medications. Norepinephrine, phenylephrine. Those sound kind of the same to me. Epinephrine, norepinephrine, phenylephrine. That's 3 different medications, okay? There's tramadol and trazodone. There's Fosamax and Flomax. There's all kinds. There's all kinds of them. Now, when you are sometimes in your Davis Drug Guide, I believe it's the Davis Drug Guide that will do this, is it will have like an alert. This sounds like such and such other med. That could come up as an alert on your MAR or in your pharmacology reference that you use at clinical. We use Lexicomp. I'll have to look next time. I'm going to look up a sound-alike med next time I'm at work and see if the Lexicomp database tells me that is a look-alike, sound-alike. So that would be the other thing to just very, very, very clear of. And when we're talking about medications, you guys, I know the generic names really hard to pronounce. If you listen to my podcast, you can hear, hey, I will attempt it, okay? So I'll go first. I'll do it. But it's so much more accurate to use the brand, not the brand name, the generic name, okay? So just to bring it back to recent events, Versed is a brand name. Vecuronium is the generic name. So it really should have been more, I was looking for Midazolam, but I pulled up Vecuronium. Well, those are very, very different, right? So going by the generic name is so much more accurate and less risk for error. Now, I will say that sometimes that generic name is a mouthful. It's really long. And with that, you just have to be really clear, like dopamine and dobutamine. Okay, so there's that one. And then the right time is the other basic one that you've learned. Obviously, it's going to vary based on where you work. When I was a student, my clinical professor, who was terrifying, Professor Rose, I've talked about her many times, love her, terrifying though. And we had, for our like 9 o'clock meds or whatever, we had a half-hour window on either side of that. So we could give it starting at 8:31 or 8:30 up to 9:30. Outside of that parameter, it was too early or it was too late. So find out what your facility considers the on-time framework. Actually, the facility where I work, it's an hour. So if I can give a 9 o'clock med at 8:01 up to 9:59 a.m. and it's still considered in that kind of time frame. It's an hour before and an hour after, which helps a lot when you've got multiple patients, right? And then with the PRN meds, with the, say it's every 4 hours, there's not that same kind of wiggle room. It's 4 hours. Like it has to be at least 4 hours. It's not, half an hour one way or the other. So just being very, very aware of that. And then with the dosage, if you're not sure, super easy, super fast to just look that up. Next time you're in clinical and you're in the MAR, if you haven't yet clicked around and had a chance to explore, see if there's like a little, like we use Epic and we use Lexicomp as our database. And I don't know if Lexicomp and Epic are like BFFs and they're always go together, if that's just a combo that my hospital uses. But there should be somewhere in your intranet at your facility a place to quickly look up medications, okay? So you can always look there. If you see an order for 200 milligrams of fentanyl, I hope you're going to go, I'm going to look that up because that doesn't sound right, because fentanyl is dosed in micrograms, right? I want to tell you a little story about when I was a 4th semester student. I was doing my preceptorship on a telemetry floor. It was an awesome experience. If you guys get an opportunity to precept in telemetry, it was great. I learned a ton. Anytime you're opening multiple vials, multiple blister packs, multiple of anything, I want you to go, whoa, let's pause. Let's relook. Yes, sometimes patients take crazy big doses. I once had a patient who took a fair amount of gabapentin, and I'd open a lot of gabapentin, but you better believe I triple checked that dose, okay? But I was working as my 4th semester preceptorship, and I was walking down the hallway, and I did it on night shift, which was great. It wasn't great for my schedule, but it was great because I just had so much more opportunity to just kind of slow down and learn. And the nurses were so willing to teach at night because it's not the same crazy hectic wackadooness like there is on day shift. But anyway, if you're thinking about a nighttime preceptorship, it can be awesome. So I walked by this nurse, not the nurse that I was working with, and I noticed he had like 7 packages of acetylcysteine open. Acetylcysteine, otherwise known as mucomist, you may have heard it called, and it is given to patients. It's like hepatic, is that a word? Hepatically protective. It's something that will protect the liver. Like acetylcysteine is what you would get if you had taken an overdose of acetaminophen, okay? And it smells like sulfur, really bad. And I can't imagine what it tastes like. So as I'm walking by and I see all these, and I think I could smell it too, I made a comment about, wow, that's a lot of acetylcysteine. And he's like, the nurse was just like, yeah, I thought it was kind of weird. You know, I had to open so many. That thank goodness the patient didn't mind the flavor. And I walked away thinking, that doesn't seem right. That's not right to me. So, you know, as a student, you can feel a little bit powerless. You can feel like, is this my place to say something? So what I did was, instead of going and confronting that nurse who I didn't really know, and again, I'm a student, I went to my preceptor, and I didn't lay blame. I didn't anything like that. I just said, this is what I saw. And just told him what I saw, and he was like, oh yeah, no, that's no bueno. So he ended up talking to the nurse. The nurse had given a massively huge overdose of acetylcysteine, had to call the cardiologist in the middle of the night and report the med error, and he was sweating bullets about having to do that, but he did it. He 100% owned up to it immediately. The patient ended up being fine, but it was just that reminder. If you're opening multiple vials, if you're opening multiple blister packs, if you're pulling a whole lot of meds out, double check your dose, double check your math, double check everything, okay? Let's see. Yeah, Erica says she'll never forget that Versed is Midazolam. I call it Midazzle, because it does amazing things for patients. But yes, absolutely, Midazolam for sure. Go by the generic name. Okay, so the right route. Some meds can be given via multiple routes. You've probably figured this out already. I'm trying to think of a really great example, like nitroglycerin, right? Nitroglycerin is a medication that can be transdermal. It can be under the tongue. It can be on the tongue in that spray or whatever that is, that buccal. Is that buccal? Is that the word for cheek? It can be an IV medication. It can be a pill. So there's like lots of different routes for something like nitroglycerin. So just make sure that you are understanding which route you are using. And again, one of those things that you wouldn't think had to be talked about, but people have died, is nurses have instilled tube feeding into IV lines. Now by the time you guys started school, most hospitals had changed to the purple top, and the name of it is blanking on me if somebody wants to pop in. It's got like a purplish connector. What the heck is it? But it's safer, right? It will not attach to a lure lock. There's no way you could instill, a syringe into that. It's supposed to be more safe. You will also see on your unit, oral syringes are not lure locked. So if you have to give an oral med and you're going to do the trick where you shoot it into the cheek, like let's say you've got a little grandma and she doesn't swallow so great, but she can handle something in her cheek, and you're going to give her a little pain medicine in that way, or a little something, and you're going to just put it right in here and let it just kind of absorb. Do not put that into a regular lure lock syringe. I know if you can't find the oral syringe, you might be tempted, right? Because it's going to take you how long to call down to central supply, get the oral syringe, what have you. But there's a huge risk of taking that syringe, and because it's got the lure lock, that twisty, mechanism, it could go onto an IV, and you could really hurt somebody that way. So oral meds only go in oral syringes. If you haven't seen one yet, they're kind of an orangey, amberish color. They don't have the ability to twist and tighten onto something. You just have to hold them in place, okay? So right route. Never give something IV that's not supposed to be given IV. Okay, and then going beyond the 5 rights, you guys. So this is where I was talking to my friends today who teaches at a school up in Northern California. And we were talking about this list and, you know, the 5 rights and what is next gen teaching. I don't even know. I mean, sometimes the tests will go up to like 7. I don't really care what NCLEX is testing people to, because that's just a test, right? At the bedside, I guarantee you, you're going to think through all 14 of these things every time you give most meds. Maybe not all, because some of them are outliers. But for the most part, you're thinking through so much more than just the 5 rights. So let's dive into some of these. Actually, we're going to dive into all of them. Okay, so the number 6 one is the right indication. So you have to know why your patient is getting that drug, right? You're not just going to give it willy-nilly because it's ordered. You're going to understand why. And this helps you understand the clinical decision making that is going on. It helps you understand the patient's condition, the care plan, the treatment pathway, all of those things. And it lets you know kind of what you need to monitor for, right? So knowing why your patient is getting that medication. So for example, nitroglycerin, that's another one. So nitroglycerin, let's say you walk in and you get report on a patient who's on nitroglycerin infusion, IV nitroglycerin. Well, nitroglycerin could be given, like say they're taking the little capsules, the little, what are those? Those little, I don't know, I guess they're capsules. Nitroglycerin capsule for angina, right? So does your patient with the nitroglycerin drip have angina? Or do they have high blood pressure? So a lot of times nitroglycerin IV as a continuous infusion that you titrate very carefully is for some patients with like really out of control hypertension. So you have to know why they're getting the specific medication that they are getting. Let's say your patient's getting an SSRI and you're like, well, I don't see anything in this chart about them having depression. Well, SSRIs are often used in chronic pain management. So you have to know why your patient is getting that medication, okay? And then we'll move on to, wait, let me hold on. Is it the I'm going to read a couple messages because Cleo's asking, is it the kangaroo system? That's what we use in Canada. You're talking about the tube feeding, Cleo. We use kangaroo pumps at my hospital. They have been updated with the safer locking mechanism. So I hope that's what you guys have there. Ari says, my nursing preceptor had me know every medication I gave and explain why the patient was receiving it. It was a great learning experience. Yeah, Ari, absolutely is. Absolutely. Okay, let's move on to number 7, which is the right formulation. So some meds come in different formulations, kind of like how maybe different indications or different routes. There can also be different formulations. Tablets, capsules, caplets, elixirs, suppositories, IV meds. Tylenol is a great example. Tylenol comes in a tablet. It comes in a capsule. It comes in a suppository, I believe, and it comes in IV form. So lots of different formulations, and probably also an elixir. I bet there is for the kids, an elixir of Tylenol. So multiple formulations for one drug. Okay, so know which formulation you are giving. And then that kind of dives into number 5, which is giving it by the correct route. Okay, right documentation is you have to document immediately after you give the meds. So when I was in my, I think 2nd semester, I was doing that ICU clinical day and I was working with the nurse and they did have electronic charting. I know that makes me sound super old, but the hospital where I ended up working was like the last one in the whole system to go to electronic stuff. So I did actually work with paper charts and paper MARs for several years. But anyway, I gave the meds, but for some reason I didn't chart that I had done it. And she did not let that fly. She pulled me aside and she said, you have to chart immediately. What if you walked away and had a brain aneurysm? Nobody would know if you had given this patient this medication. I was like, that makes sense. The other reason is you obviously want it in there in a timely way. Saving things to chart later is a recipe for disaster. Try not to do that. Definitely 100% don't do it with meds, okay? And you also, maybe there's some monitoring parameters that you need to chart with it, like their pain level. If you're giving an antihypertensive, you would need to put their blood pressure in there. What else? Pain level, blood glucose level, things like that. So chart right away, okay? And then number 9 is the right response. Okay, so this is kind of like your nursing judgment, your clinical picture of the patient. So along with knowing why your patient is getting the medication, you need to know what response you're expecting to happen, right? When you do your care plans, don't you have to write what your expected outcomes are for your patient? That's kind of what you're doing with this. You want to know what you're expecting to happen. A lot of nursing is going into a situation and you kind of have an expectation of what you expect to see, right? You expect to see certain things in a patient with heart failure, right? You expect to see certain things in a patient with pneumonia. And then if things are worse than what you expect or different from what you expect, or maybe you have a patient, who doesn't have trouble with respiratory. So you don't expect to see respiratory difficulty, but then you do. So a lot of nursing is you go in with a set of expectations about what would be normal for this patient, and then things that are abnormal are what are going to, clue you in like, oh, I got to do something about this. So knowing the response that you're expected to get from a med is really, really important. Like, let's say my patient's got a heart rate of 120, and it's not because they're dehydrated, and it's not because they're nervous. They're just physiologically doing crazy things right now, right? I'm going to give some IV metoprolol maybe. And if the heart rate doesn't come down, well, then I know the response I was expecting was a change in heart rate, not necessarily a change in the blood pressure, because metoprolol could also change the blood pressure, and it will probably bring the heart rate down. But if it didn't, that would be something to call the MD and say, hey, I gave them metoprolol. Heart rate only came down to 115. What do you want to do about it? Okay, so you want to know the right response. If I was giving metoprolol for blood pressure, maybe the blood pressure is 180 over 110, and the physician orders metoprolol, and I give it, and I know the response I want is an improved blood pressure, and it doesn't happen, well, now I know, okay, I got to call back. I got to say, hey, the metoprolol didn't really do much. Blood pressure is 175 now. Would you like to try something else? Another dose, maybe some hydralazine, hint, hint. So knowing the response that you're expecting, okay? And then number 10 is the right compatibility. And so that, I did a whole podcast episode, you guys, about safe IV medication administration. I don't know the number off the top of my head, but I'll find the link and I'll put it in below this video. But medications will often be a couple different things to think about with IV compatibility, okay? Actually, let's talk about 3 things. We're going to talk about piggybacks, pushes, and infusions, okay? So with IV piggybacks, okay, so that's that antibiotic that you're hanging piggybacked against their main fluids, right? And main fluids, most of the time, it's going to be normal saline or maybe some D5 half NS with 20 of K, something like that, right? Most of the time. And most saline's pretty, innocuous. It's going to be compatible with most things. However, I still want you to check the IV compatibility of your antibiotic and your IV fluid, because sometimes you'll be surprised and you'll be really glad that you checked, especially if that IV fluid is lactated ringers. Lactated ringers does not play nice with everything. And you'll see tons of times it's set up as the patient's primary infusion, and someone piggybacks something against it, and I can pretty much always guarantee with pretty good certainty that they didn't check. And I have seen many times when I've gone to check that there is something piggybacked with LR that's not compatible with LR. So always check against your IV fluids. I know they seem like no big deal, but they can be incompatible. So that's that one. What I do, if the patient's got LR as their main fluids, what I would do is, let's say they're going to get their antibiotic, and I can't think of one off the top of my head that's definitely incompatible. but they're going to get an antibiotic, and let's say it's not compatible. You do the check, you do the IV compatibility check in your Lexicomp or whatever you're using, and it says, no, don't do this. So you could just, it's a more work, yes, but you could go get a bag of saline. It doesn't have to be a huge bag because it's just what you're piggybacking against, right? Set it up on another pump. Program it. Here's what I do. I mean, you can always double check with your facility if there's a policy around this, but set it up at like 10 mils an hour, okay? And then piggyback your antibiotic against it. And then set an alarm. If you can set an alarm on your pump to alarm at you when it's finished, then you can come back, switch them back over to their LR at that time. Okay, so that's just one way to do it, but don't piggyback things against LR if they're not compatible. Then we have IV pushes. Okay, so IV pushes are those meds that you've gotten the syringe and you're going to attach it to your tubing and push it into the patient, right? And I don't know, students, if you do IV pushes, so file this away for when you're working. Again, if LR is running, or maybe there's something else running through that line, maybe you've got some octreotide running through the line or whatever it is, I don't even know. Don't assume things are compatible. You want to do a little flush before and after with whatever the compatible solution is. And it's usually going to be normal saline, but not always. You have to check, okay? I call that doing a saline sandwich. Do a little saline, do the med, do a little saline, and then the LR or whatever can run through safely, okay? So that would be compatibility. And then Y-siding meds together. So somewhere I have some IV tubing. Oh, Ashley, let me just look and see if I have any IV tubing. But Ashley did an IV push today. Look at you, girl. I don't think I do. Sometimes I have some random supplies in here, you guys. Oh, I do. Hang on. I have some. Okay, I'm going to just show you this real quick. So your IV tubing will have, I have to untangle it, this spot, like, here's the patient end, right? There's the business end, and then this spot. So you'll have, if your patient's on a bunch of stuff and they've only got one IV site or two IV sites and they're on a lot of stuff, there'll be another med attached here and it infuses in. So it's mixing together from this point on, right? So those meds have to be compatible. We call that the Y site. So when you go to your Lexicomp or whatever it is that you're using for your IV compatibility, there will be something called like a compatibility checker, and what you're looking for is the Y-site compatibility. And that takes into account that the meds are going to be in this space together for a pretty short amount of time. So that's why it's very specific to the Y-site compatibility, okay? So if you're working in critical care especially, or a step-down unit, you're going to have things Y-sided together. In the ICU, it was not uncommon to have 3 or 4 things Y-sided together on all 3 ports. Okay, so like 10 or 12 things running at the same time, things Y-sided together, or you may use a manifold, or a bridge is like a slang term. It's more of like a rectangle with a bunch of different ports on it. That's actually a better way to do it, but down and dirty Y-site. So you want to make sure they are all compatible, and it can be a bit of a puzzle. So what you'll do is you'll put them all into your compatibility checker and then get that report printed out, stick it on the WOW so that it's easy for everybody else, okay? So that's about IV medications. Some PO meds, you know, they're not going to be compatible with other PO meds. That's why it'll say, like, take your calcium at a different time of day than you take your levothyroxine, okay? Or I think antacids is another one. You have to kind of figure out if they're on certain meds, you don't take them at the same time with antacids. So compatibility, that's why. It's like, listen to the podcast on that because I talk a lot more about it. Okay, Erica uses Lexicomp for compatibility. Oh, yay. Yep, me too. I love Lexicomp. It's super handy. Okay, and then enteral medications. I know this is a pain in the butt, but best practice is to do them one at a time. So if you got a patient with 8 different PO meds that you are crushing, dissolving in those little tiny cups, and then pulling up into an enteral feeding syringe, not a regular syringe, not one with the lock on it, but that tube feeding syringe. Technically, you're supposed to do them one at a time. I guarantee you, though, probably within your first week of practice, you're going to see nurses just mix them all together. Technically, you're not supposed to do that. It's supposed to be one at a time. I looked into this because I was really curious about it, because it was a lot, and it's a lot of fluid. If your patient has fluid overload, it's a fair amount of fluid to get the little, flushing after each one. How many mils is that? Maybe 20 to so mils for each med. Flush before, flush after, blah, 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 blah. So it can add up, right? So just pay attention to that. You're going to see people mix them all together. Be the change you want to see in the world, right? That's what I always say. And you can always, fall back on policy, fall back on the evidence, fall back on best practice. If, let's say, you're orienting and your preceptor is giving you a hard time about it, you can always fall back on that. Okay, right contraindications is number 11. You need to know what situations would cause you to hold the dose or question a dose. Or medication. This could be their vital signs. So maybe you need to know that if they're getting metoprolol, you need to know that if their heart rate's below 60 or the blood pressure's below, 90-ish, you're going to be holding that medication and letting the MD know when they come by on rounds, right? It could be a physiologic condition. So let's say your patient's creatinine is 3.2. Are you giving the furosemide, or are you going to call the MD and say, hey, I want to make sure you knew that Mr. Johnson's creatinine was 3.2 this morning and he's got 40 of Lasix order. Would you like to continue with that? Sometimes they'll say yes, but that's, usually as the creatinine bumps up, the furosemide is just going to make it worse. So they may do something else for a diuretic. Other medications that the patient is getting, lots of drugs have, again, drug-to-drug interactions. Someone taking MAOB inhibitors may not, they don't play so nice with opioids. They don't play so nice with SSRIs and TCAs. So you want to be aware of those things. And then, of course, allergy would be the big one. Okay, number 12 is the right care area. So this is one that I hadn't really thought about, because I only ever worked in the ICU and in the PACU. So I worked only in high acuity areas. But thinking in a broader sense, there's a bunch of different care areas in the hospital, right? And no, you wouldn't give some medications in some areas just because of the level of monitoring that is required. So lots of medications can only be given if, let's say, the patient's in a monitored unit on that telemetry monitoring, has a nursing to patient ratio that is safe for that kind of monitoring. A great example of this would be like vasoactive meds like norepinephrine or phenylephrine or epinephrine. Things like that are not going to be given outside of a monitored unit. Propofol, that sedative, that medication that puts people to sleep. Ketamine infusions, paralytic agents, not given outside of those high acuity, very closely monitored care areas. So make sure you're in the right care area. And this kind of ties into the next one, which is the right policy. So care area could be covered under policy, but also beyond that, know your facility's policy about certain meds. I'm trying to think of how many years ago it was. Maybe 7 years ago. I'd have to look it up. But my hospital changed the policy that nursing was no longer allowed to push propofol for patients getting conscious sedation. So there must have been an incident, is what I'm thinking happened. So even though we had done it for years, and we had done it for, I believe we could still do it for, no, I'm trying to think. There was one caveat where you could for a rapid sequence intubation because the physician was right there to rescue the patient, to intubate the patient or breathe for the patient. But if it was conscious sedation, what the MD would have to do is get another MD to come in for that administration of that sedative agent. So even though we had been doing it, we suddenly weren't anymore. We were no longer covered by policy. So make sure you're covered by policy for things like that. And then the final one, you guys, is the right environment. And this is where you really have to advocate for yourself and advocate for your patients. So the area where you obtain, where you prepare, where you administer medications. So that could be, multiple areas, right? You're going to get it from the Pyxis room. You're going to maybe prepare it in the Pyxis room. Sometimes you prepare things right at the bedside and then giving the medication at the bedside. All of this should be 100% free from distractions, okay? And it is fine, okay, perfectly acceptable for you to tell other people to stop talking to you, okay? It's easy with your coworkers because they get it. You can just say red zone, and they'll be like, oh yeah, you're doing your meds. You're in the red zone. Sorry. And that, that's that, right? And that's fine. It can feel harder when it's a patient or it's a family member. So I cannot tell you how many times. It's probably every time at the bedside when I'm looking at my meds, figuring out, is this the right dose? Is this the right whatever? I'm thinking through all of these things while someone's like asking me questions, blah, 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 in my ear. Distract. So finally, I stood up for myself. And after I did that, I realized, oh, that was really easy. I'm just going to keep doing that. In the ICU, people are stressed. I totally 100% get it. Family asking questions about every single thing because they want to know. They're very concerned. 100% get it. I love teaching families, but not when I'm given meds, not when I'm looking at, trying to figure out how to titrate their norepinephrine or how much insulin to give or do they need a heparin bolus or any of that. And I just said, while I'm giving meds, I'm going to ask that you hold your questions so that I can focus for your loved one's safety. And when I say it like that, for your loved one's safety, people are, I would say most reasonable human beings are 100% on board with that. So it's okay to ask other people for your loved one's safety. Or even if it's the patient who's just, some people just, they can't stop talking. And you could just say, okay, Bob, I know you want to talk about what you're going to do when you get out of here and the cheeseburger you're going to have, but right now I need to focus on this so that I give you the safe dose of medication, and then we'll talk about our favorite burger joints, okay? And then Bob will be like, okay, I get it, I'll for now. So it's 100% fine. You can advocate for yourself. With that, you're advocating for the patient, okay? So those are the things that I recommend you be thinking about, kind of going beyond just the 5 rights and just making yourself like bubble wrapped and your patient kind of bubble wrapped in this whole, framework of how you think about medication administration. Okay. So was that helpful? Do you feel better about anything? Do you have any questions? Let me see, what time is it? It's 5:15 where I am. I'm not seeing any questions, but there is a little bit of a delay. So I'll wait. I'm going to have a little bit of water. Okay, I don't see any questions coming through. What always happens is as soon as I'm like, okay, bye, then they start coming in because there is like a 30-second delay. But let me tell you what's coming up on the podcast. So this week, today, tetralogy of Fallot is what I talked about. So if you're at all interested in cardiology, pediatric cardiological defects, that is a really interesting one. If you are heading into nursing school, I'm doing a workshop on Sunday, and I'll put the link to that below. It's for new students going into nursing school, kind of identify ways to set themselves up for success from the get-go. And then boot camp goes on sale on Sunday as well. And the new planners are going to come out May 1st. Maybe a little earlier. Nah, I think May 1st because I'm going on vacation soon. So I need to go on vacation, and then when I get back, we'll have the new planners. Okay, so if you've been looking for your July version, It'll be up in May. Plenty of time for you to get it. Okay. So we're closing out today. Thank you guys. I hope that was helpful. I'll put the links. I'll put that below, Stormy, so that you have it. Let me see. Let me just grab it again and put it right here. There you go. There you go, Stormy. I just popped that in. Okay. I'll see you guys very, very soon. Okay. Bye.